apart from MSK Imaging too. Over to you, ma'am.
Hi, thank you so much for the introduction and the invite. I hope my screen is visible and audio is clear.
Yes, ma'am, it is.
Yeah. So, hi guys, we have been discussing about the wrist for past an hour. So now what we are going to see is the wrist tendon pathologies. So if I start from here, so we all are aware that if we talk about the tendons around the wrist, there are an extensor tendons and there are flexor tendons, correct? So we all are aware of this. So extensor tendons are divided into 6 compartments on which I'm going to come upon later, and the flexor tendons, except a few, most of them pass through the carpal tunnel, right? Now, what do you think would be the ideal imaging modality to look at the tendons? Ideally, I would say ultrasound beautifully shows all the tendons. So, ultrasound is a great modality because with ultrasound, you can diagnose, you can simultaneously intervene. But MRI is also, if done with a nice FOV, good, you can pick up all the abnormalities well. And in this talk, that's why I'm trying to focus on the MRI and show you that MRI is equally good as ultrasound to show you all the tendon pathologies. When we talk about pathologies, what do you think would be the cause of having some tendon abnormalities? So either there is some friction or degeneration which is happening. Otherwise, there might be specific cases which you get for trauma, infection, inflammation, or maybe some other causes as well. But the most common would be the first category, which we are going to see as we move forward. Now, if we talk about pathologies to the tendon, right? This is not something which is specific to the wrist. It is something which is specific to all of the wherever you see tendons. So the spectrum usually starts with tendinosis or tenosynovitis, and you can have a tendon tear. So this is the actually the spectrum which you see once you're talking about the tendon pathologies. So tendinosis means when you see just increased signal within the tendon. So just see the other tendons. See, the cursor is pointing to the other tendons, and you can see how dark all the tendons look like. So normally the tendons should look pretty dark. However, in this case, this tendon shows some increased signal within. So this is what is labeled as tendinosis, when there is misorganization of the collagen fibers or there is loosening of the collagen fibers. So we start to get some increased signal. So that is what we label as tendinosis. When it is associated with tendon sheath fluid, as you can see over here, you see some tendon sheath fluid, it becomes tenosynovitis. And sometimes the tendon may get torn. So you can see one bit of tendon here and one bit of tendon here. So there is a tear within the tendon, right? Along with obviously synovitis along the tendon sheath. So this is further gone up to the stage of tear. So when we are doing a particular imaging, we are trying to figure out whether the pathology belongs to which of the categories, whether we are still at tendinosis or tenosynovitis, or are we progressed to tendon tear. Why is it important? Because if it is still tendinosis and tenosynovitis, we are going to manage it conservatively. But if it has gone torn, we might need to think what we need to do to get back the patient functionality. So let's start with the common things first. So first thing before we go into pathologies is what are the extensor compartments. So extensor compartment or the extensor tendons are divided into 6 compartments. Compartment 1 is constituted by abductor pollicis longus, extensor pollicis brevis. Compartment 2, you have ECRB, that is extensor carpi radialis longus and brevis. And this is very important. So this projection you try to pick up on ultrasound as well. So if you see this projection, this bony projection in the distal radius is called as Lister's tubercle. So if you pick this, you know the tendon which is on the radial side is the compartment 2, and the tendon which is on the ulnar side is compartment 3, which is your extensor pollicis longus. Then you have a bigger compartment where you see at least 4 tendons, which is your extensor digitorum complex along with extensor indicis. Then you have the smallest compartment, that is your extensor digiti minimi, the 5th one. And lastly, overlying the ulna, in the ulnar group, you have your extensor carpi ulnaris. So if you're doing this regularly, you remember all the compartments. But if there is any doubt, you can Google and figure out which compartment it is. But most important of it, which I really want all of you to remember, is compartment 1 and compartment 6. These are the two compartments which are most commonly involved. So the most common is 1 followed by 6. And I'm going to show you those compartments particularly. But we remember that the compartment 1 is the most commonly affected, followed by compartment 6. Compartment 1 has two tendons, pollicis longus, abductor pollicis longus, extensor pollicis brevis, and compartment 6 is extensor carpi ulnaris. So let's start. As I said, compartment 1 is most commonly affected. That's why I'm showing it to you first. So what is the condition that affects the compartment 1? It is called as decurving tenosynovitis. What kind of tenosynovitis? We just read tenosynovitis. So we should see some inflammation in the tendon along with some tendon sheath fluid. That will make it decurving tenosynovitis. That's particularly clear. But if you try to understand the pathology, you get this term, that is tenosing tenosynovitis. So what happens? The tendons are running in a sheath, right? So the sheath starts to become thicker and thicker. I'm so sorry. So the sheath starts to become thicker and thicker. The sheath is becoming thicker and the tendon is having friction while movement within the sheath. And that's why, because of this friction, you tend to get tendinosis as well as tenosynovitis, right? So we might, if we do ultrasound, it might be a little difficult with MRI, but with ultrasound, you will be even able to pick up the tendon sheath thickening, right? So that is actually the cause, which is causing restriction of movement of the tendons within that particular compartment. How do you treat it? Usually you try to treat it conservatively and you do ultrasound guided injections. Sometimes you might need to resort to a surgical intervention, but initially most common management is conservative. So let's see an example. So can you see this? We are on the radial side. This is scaphoid. So we know we are on the radial side, but you'll get scrolling images so you can see radius, right? So you're on the radial side. And these are the two tendons. And you can see they're lying within this sheath, which has fluid within it. So tendons look increased signal with fluid within the tendon sheath. So this is your classic case of decurving tenosynovitis. But as I told you, usually the management would be localizing and conservative. But sometimes if it is not resolving, you do interventions, right? For that, you need to know this very well. This is very important. So there, the tendon sheath is very variable. So normally both the tendons, longest looks a little bigger than the brevis. That's why the size difference is shown on the image. So both the tendons are normally running in a single sheath, but there are variations. So this is the most common type where both the tendons are running in the same sheath. But there can be variations. The variations would be, there is a, so it is, the variations is given a name as classification, which is a Hiranuma classification. So there can be a complete separation of the sheets. So they are running together, but they have separate sheets which are holding the tendons. The next variation is an incomplete separation. What happens in that? Proximally, they are lying in a single sheet, but as they come towards the wrist and further along, they have distinct sheets for each one of them. So that's an incomplete compartmentalization. And then there is another variant in which you do not have an extensor pollicis brevis tendon at all. Now you would be wondering, why do we need to know sheath? Whether they run in 1, 2, 3, 4, how does it matter to us? It does matter. So I'll show you an example. So this is an ultrasound image which showed little increased signal with minimal fluid in the tendon sheath. The patient was not responding to conservative management and an injection was taken as a call. So the needle was pushed in. This is your brevis and this is your longus. We are into this sheath. When we inject the fluid, can you see in this case, the fluid was filling both the sheaths. So when you are pushing and injecting in such a case, if you are only limited to one sheath and there are two distinct sheaths, you are going to inject the entire content in one sheath and the symptoms from the other sheath are not going to get resolved. So if they're while inject, so most commonly it will be difficult to make out if it is not inflamed. But while injecting, you are very sure because once you inject, you can see the injected going into the tendon sheath. If it is going only into one tendon sheath, then means there is a separation of the tendon sheaths. So you might need to withdraw your needle a bit, come to this tendon sheath also and inject here as well, right? Otherwise, the symptoms will not be resolved because you just injected in one sheath. So it is very important while you are intervening to be careful that you see that there are not two separate sheets. And if you figure out that there are two sheets, you need to inject in both these sheets, right? So this is very important, right? So same thing compiled over here. So when there is a complete separation, you need to figure out whether you need to inject in both the sheets or one sheet, and you need to pull out your needle and be sure that you have injected in both the sheets. And sometimes even if they are planning for a surgical intervention, if you tell them that there are different sheets which you have realized while injecting, or you can figure out like a septa on an ultrasound, then you can tell them that you need to release two, and you can if only one is inflamed, that when which one is inflamed, which they need to release. So this was extensor compartment 1. So you all remember the mnemonic APL EPB, and it is called as decurving stenosynovitis. Now moving from there to the next compartment, which is most commonly affected, is compartment 6. This is your extensor carpi ulnaris tendon, that is your ECU tendon. So again, very important, second most commonly affected extensor compartment, and these are the things which you are going to see very commonly. One important thing which I didn't mention in the beginning, whenever you are doing a wrist joint MRI, ask them to put pain marker. Because then if you see your pain marker on extensor compartment 1 sheath, you know that you have to carefully look for decurvings. If you see the pain marker on the ulnar side, you know you need to carefully look for probably TFCC related pain or ECU related pain. So that gives you a very clear idea that what you really need to look into, because otherwise you might see small, tiny things here and there everywhere. So pain marker is very important with the wrist. Moving back to compartment 6 is like a fibroosseous tunnel. So your distal ulna along with the sheath and in between runs the extensor carpi ulnaris tendon. So let's see this. So this is our entire extensor tendons. 1, and on the ulnar side, you have extensor compartment 6. So this is your 6, and this is your extensor retinaculum, which is holding all the tendons in place, right? But for ECU, there is a special sheath, which is this red one, which is holding the ECU within the groove related to the ulna. So if you try to see this above black band, which is going like this, is your extensor retinaculum. So this black band is your extensor retinaculum. But you see this thin black band deep to it running across like this. This is your ECU subsheath. So this is a sheath which is sorry, which is holding the ECU tendon in place. So whenever you're looking at the ECU tendon, you need to look at this area also carefully. Again, once you start to analyze, the spectrum remains same. Here you see that there is increased signal within the tendon and which looks bulkier as well. So this becomes tendinosis. Along with this tendon sheath fluid, we call it extensor carpi ulnaris tenosynovitis. Then another case which we saw in the beginning as well. So here is ECU tendon. Few peripheral fibers are intact over here, and there is this tear which is running through and through the extensor carpi ulnaris tendon. Right, so this is your extensor carpi ulnaris tendon tear, which is split tear because the tendon is split into the two parts. Then you can specifically have a subsheath injury. So if you see this tendon has some increased signal, but very minimal, right? But if you try to trace the subsheath, which I can do over here, but I am not really able to figure out this attachment over here, and there is some edema over here. So then an ultrasound was performed for this patient, and the tendon was subluxing out from here a little bit. Unfortunately, I don't have put the video over here, but that's the importance of ultrasound because you can see the dynamic things as well. So this is a subsheath injury which is leading the tendon to sublux out. So which you need to pick up and look carefully for. So we have discussed the two most important compartments, that is compartment 1 and compartment 6. The other other common compartments to be affected are compartment 2 and 3. So what will happen? So we remember our compartment 2 is formed by ECRL and ECRB, and compartment 3 is EPL, extensor pollicis longus. So what happens in these two compartments? So EPL crosses over the compartment 2, and this crossover leads to something which is called as intersection syndrome. So whenever our tendons are crossing over each other, there can be friction between the two compartments, which can lead to tenosynovitis of both the compartments, especially at the level of crossover, right? And that is called as intersection syndrome. It can happen distally at the level of wrist or little in the distal forearm, which is called as proximal intersection. And I'm going to come upon that in a bit. So this is your distal intersection when your compartment 3 at the level of wrist. Can you see at the level of wrist? 3 is crossing over 2. In the distal forearm, when compartment 1 crosses over 2, it is called as proximal intersection syndrome. So just to remember an easy way, 2 is always going to get hampered. The 2 is the one which is beaten by everybody. So distally 3 and proximally, proximal means early, so 1. So 1 is beating 2, just a way to remember, not beating really. So 1 over 2 is proximal and 3 over 2 is distal. Another important point over here, if you notice, normally this area would not be included in your wrist FOV. Wrist FOV is limited and you cover only this much area. So this usually might get missed from being covered in the wrist abnormalities. But if you have put a pain marker, the pain marker would be lying over here because patient will be tender at the point of crossover. So the technician will be smart enough to increase the FOV and include this area. And that's again to point out the importance of the pain marker. So let's see this beautiful case. And in this, I want you to keep an eye on compartment 2 and compartment 3. So 2 here and 3 here, right? Similarly, 2 here and 3 here. So Lister's tubercle over here. Now, as it goes further, 3 has started to cross across, right? Now 3 is going across the 2. 3 is going across the 2 and you can see it is pretty inflamed. But let's go further and you see 2 as it is further above here. So this is your 3 which is crossing over the 2 and the 2 is also inflamed and you can see the pain marker is exactly at that level. So you know that there is tenosynovitis of both the tendons and this is a distal crossover or a distal intersection syndrome, and now it has gone further out. So on your sagittal image, coronal images, again you see inflammation in both the tendons. At the level of wrist is a distal crossover. This is another case to show you the proximal intersection. So this is 1 crossing over 2 over here in the distal forearm with inflammation, which you can pick over here. And the pain marker was exactly over that area. That's why this was covered, right? So this is the area which is pretty proximal and you see crossover happening in the distal forearm and you see these tendons are crossing over and there is inflammation in that region which corresponds to the site of pain marker. So this is your proximal intersection syndrome. Lastly, we are left with 4 and 5, which are not very commonly affected though. But sometimes you might see a tenosynovitis of those compartments as well. Like in this case, you see an extensor compartment for tenosynovitis with tendon sheath fluid over here. So till now we have tried to cover up all the extensor compartments, right? All the extensor compartments on all the extensor tendons. Now what we are left with the flexor compartment. So you have your flexor compartment or the flexor tendons which run within the carpal tunnel. There is not likely to be a solitary tenosynovitis, but in certain cases you might land up getting. But usually, so just to show you on an MR image, so this is your carpal tunnel. These are the bands which is there, and these are all your flexor tendons, along with the median nerve sitting within the carpal tunnel over here. And this is your Guyon's canal, this triangle over here, in which your ulnar neurovascular bundle is running over here. So this is your carpal tunnel and this is your Guyon's canal with the ulnar neurovascular bundle. So what I was trying to say with respect to pathologies, usually they are involved as such the entire compartments. Sometimes you might see a solitary inflammation as well. So in this case, can you see the entire compartment is involved and there is a lot of inflammation. So there is a lot of fluid along with some synovial thickening. Actually, this was a case of known rheumatoid arthritis, and that's why there was flexor tenosynovitis. So you see certain scenarios like this in which flexor compartment is involved. Another case in which you see how the all the tendon sheets are flooded with fluid and there is little increased signal within them. So this is a case of again flexor tenosynovitis. So now what we have been discussing is initially the friction which is happening, which is much more common in the extensor compartment. And that is something which you're going to account or encounter most often in your clinical practice. But there would be certain other indications for which the patient might be coming to you. So one of those would be trauma. So in trauma, in this patient, you can have flexor injury if the trauma is like this or like this, depending upon that, you know which compartment you need to focus on. So in this, if you try to see compartment 1, 2, and 3 are preserved, and also these 6, but you do not see any extensor compartment 4 and 5 tendons. So there was a sharp injury and the tendons were cut, and you can see these stumps in the distal forearm and the proximal hand. So this is a extensor compartment 4 and 5 tendon injury post trauma. So what you usually need to do is you need to go back to these images and check which zones are involved. So if you understand, in our case, zone 8, 7, and 6 were involved. Somewhere the stump was here and here. So the injury extends from zone 6 to zone 8, right? So this is for extensor compartment. Similarly, you have zones for the flexor compartments also, which are separate for the thumb. So you can refer to these images. They're available online. And then you can always mention that which zonal injury it is, because the clinician might need to take a call based on that. So when I talk about trauma, what all do you need to answer? So first of all, you need to tell which all tendons are involved, where are their stumps, proximal and distal stumps, and how much is the gap or the retraction between the two stumps. Obviously, you need to look for associated injury, especially on the flexor side, you need to look for median nerve and ulnar neurovascular bundle injuries, right? So this is kind of the report for the last case which we saw. So the zones, which compartment tendons were involved, and where were the tendon stumps lying with the gap, right? So this is how you need to mention all the points. Then the last two things which you can would commonly actually encounter would be infective and inflammatory tenosynovitis. It might be sometimes difficult and tricky to differentiate two just based on imaging. History really plays a very important role. If it's polyarticular involvement, then you're more likely thinking of something which is inflammatory, or if it is more of other involvements as well, there is some arthropathy along with infective arthropathy, then you are thinking in terms of infective arthritis. So in this case, you can see that there is fluid, but can you see there is a lot of synovial thickening along with it? There is all this synovial thickening, and there is a lot of soft tissue edema which is associated with it. So this was actually a proven case of tubercular tenosynovitis. It might be sometimes difficult. I completely agree to differentiate it from the inflammatory etiology. Just to show another case, so you see little tenosynovitis over here in the flexor and extensor compartments. But in addition to that, you see some marrow edema, a lot of distal radioulnar joint effusion, with some mild synovial thickening over here. So this was a case of RA. So we knew that this is going to be an inflammatory arthropathy with inflammatory involvement. Now, this is almost the last slide, and I really want all of you to attempt. What do you think? So I give you choices of infective versus inflammatory. I think chat boxes would be active for you. If you guys want to attempt, it will be really good. Just last 1 minute. What do you see? Okay, so you see tenosynovitis extending from the wrist. Very good, Dipanshu. So you see tenosynovitis along with the wrist with multiple bodies. Can you see these are very symmetric, tiny bodies? This raised us a concern that these are rice bodies, as Smita has mentioned. So that was something which gave us a clue that this might be inflammatory, right? But it is pretty confusing. There's not that much soft tissue edema like usually you see more with the infective pathologies. So we were already inclined towards inflammatory, but then we went back to the osseous structures and saw them. So you see in this distal radius, you have already started to develop osseous fusions. There is osseous remodeling, flattening of the bone. So this was, then we went back and checked. This was a known case of rheumatoid arthritis, which has pretty progressed in the wrist. And now he is presented with the acute complaints of finger pain. So this developed tenosynovitis in the finger. But the important message over here, always try to look at all the other findings which we have been discussing in the entire session over here, right? So with this, and along with these findings, together we were pretty confident that this is most likely inflammatory etiology. So to sum up, whenever you're talking about wrist, you're looking for something, put a pain marker. That's not only limited to the tendons, for ligaments, for any pathology, it will give you a localization. Which area do you really want to look for? Whenever you are looking for the tendon pathologies, try to put your tendon pathologies into one of the categories. Then, if there is, obviously, you are trying to figure out the cause. If it's very specific, something like decurvains or ECU tendinosis or tenosynovitis, then you're pretty sure what you're looking for. Otherwise, always try to, if it is like multiple, extensor plus flexor compartment tenosynovitis, you know there's something more to this, right? Or you see a lot of synovial thickening with only single tendon sheath. Then try to figure out the cause, try to look for inflammatory infective markers so that you can be wise enough on your report to give some clue to the clinician that what we are looking at. Thank you so much for your time and patience.
Thank you so much, ma'am, for the wonderful lecture.